Good morning, everyone. So I need to cover lots of things in next 25 minutes. Don't expect you will get any spoon feeding here. Okay, so I'll give the stimulus. I'll give an idea what to be read before you go for the exam. So to begin with, always I like to go through a case scenario. Is a 55-year male patient. So diabetic, hypertensive, came with severe community acquired pneumonia, H1N1 positive. So as usual, ventilated for 4 days. Started having fever, worsened infiltrates on X-ray, increase in FiO2 requirement. So we sent again one more deep tracheal aspirate, ET culture or ball, whatever it may be. So if at all you are expecting some organism, okay, what is your organism of expectation and what is going to be the sensitivity? So it's a common pattern of organisms, okay, so common pattern of sensitivity or the resistance. So this is something we are going to get. So if you see, so it is definitely a drug resistant gram negative organism. So okay, we crossed something more than the MDR, we reached to XDR now. Okay, so then it's a gram negative organism. Always, most of the time, 90 to 95% we are going to get the sensitivity to either some sort of tetracycline or maybe aminoglycoside, rarely to quinolone, but it is going to be sensitive to colistin kind of this one. So if you see the origin of drug resistance, okay, so when a new antibiotic came across the pipeline into the utility, so maybe within 5 years there will be origin of resistance. If you take any antibiotic, so maybe hardly within 3-4 years we are going to get the resistance. But some antibiotic, there are some antibiotic called revisited antibiotics, maybe fosfomycin, okay, so minocycline, polymyxin B. So these are all the revisited antibiotic. Their resistance already exists in the healthcare community. So we can land up with the origin of the resistance even before like we have proper formulation in our hand. So again, by definition, so we need to simply understand there is something called multi-drug resistance organism, XDR, so extensively drug resistant and pan-drug resistance, okay. If an organism is resistant to a single agent of 3 or more group, then we call them as a MDR. If it is only sensitive to 2 agents of 2 groups, okay, what I showed, it is sensitive to only tigecycline and colistin, which is an extensively drug resistant. If it is resistant to all the agents of like which supposed to be given, like MDR gram negative or maybe gram negative organisms, which are the agent it expect to work. If it is resistant to all the agents, then we label them as a pan-drug resistant. So this is just for basic clearance, okay. There is something called intrinsic resistance, okay. Suppose you can't give vancomycin for gram negative organisms, okay. So that is an intrinsic. If it's not able to use the vancomycin or any glycopeptide for gram negative, that is called intrinsic resistance. There is something called circumstantial resistance, okay. Suppose sometimes they will put on paper, so which is going to be in vitro sensitive, but in vivo it is not sensitive. That we call it as a circumstantial resistance. Many times it's going to be applied in case of ESBL organism. They will give sensitivity to piperacillin tazobactam, okay, cephalosporin sulbactam, or maybe some aminoglycosides, but at the field, at the bedside, we are not able to use any sort of agents for the ESBL organism. That we call it as a circumstantial resistance, okay. So then there is something called acquired resistance, so which results from the mutation in existing DNA of an organism or acquisition of the new DNA, which we are currently worried. So acquired resistance is the one which is leading to all these MDR, XDR and that of the pan-drug resistance. So again, so genetic basis, there is something called transformation. When an organism which is having the resistance, which is going to die, which is going to transfer its genetic material into the fellow organism, that we simply call it as transformation. So conjugation is something plasmid mediated. Plasmid are the circular small fragments of the DNA which are going to carry genetic material of the resistant DNA from one organism to another organism, that which is the major spread of resistance. We call it as a conjugation. Transduction is some viruses, like we know, they are able to infect the bacteria. They can carry the genetic material which is having the resistance pattern, that we call it as the transduction. This is the genetic basis. But what exactly happens at the antibiotic and the organism level is, this is going to happen. If you see, most commonly used antibiotic in critically ill patients belongs to beta-lactam. Maybe cephalosporins, penicillins, okay, carbapenems or maybe monovectam like, that is astrianol. So the main mechanism of drug resistance for beta-lactam, so we know that beta-lactams are going to act on some enzyme called transpeptidase, which is very essential for the
So building up of peptidoglycan, which is a cell wall component. Whenever there is a beta-lactamase production, which is going to present in this periplasmic area in the bacteria, which is going to destroy this beta-lactam ring. Okay, so like that quinolones, so generally, so they inhibit the DNA gyrase and topoisomerase 4, so causes the lethal breakdown in the DNA of the bacteria, so that they will kill the bacteria, means they stop the growth of bacteria. But whenever there is a mutation, which is going to hamper this mechanism. Again, it's true for tigecycline and aminoglycoside also, which inhibit the growth of the bacteria by inhibiting the protein synthesis. Okay, so there is something called aminoglycoside modification. Okay, so there are mutations which can modify the aminoglycoside molecule itself. So that is the pattern of mechanism of resistance for aminoglycosides. Again, so all of you are expected to know this famous classification of beta-lactamases before you go for exam. That is called Ambler's classification. There are some non-metal contained like beta-lactamases, we call it as serine enzyme, and metallo-beta-lactamases, which are going to contain the zinc, which currently we are worried in our clinical area. Again, it's been classified as class A, group A, C, D, and group B, which contains NDM, that is New Delhi metallo-beta-lactamases, IMP, imipenem, VM is Verana intermedia. These are some funny names they given for these like resistance pattern of beta-lactamase enzymes. Group A, which is containing most of them are ESBL, CTXM, temonuria, sulfhydryl variant, Klebsiella pneumonia, carbapenemases. These are the group A. Serine containing beta-lactamases. Group C, which is AMP-C. So AMP-C is worrisome because the pattern of resistance which is going to created by this AMP-C is an inducible pattern. Means if one organism got this AMP-C, which can create the resistance in an exponential way. That's why it is called inducible resistance for this AMP-C. So only option will be carbapenems, or we can try with some sort of cefepime for the AMP-C group of organisms. Oxa, which is more common in Acinetobacter, that belongs to group T beta-lactamases. Again, so in India, we are harboring all variety of resistances. So currently, we more worry about the metallo-beta-lactamases, but it's 100% sure we came across all the groups of beta-lactamases in Indian ICUs. Again, this is the timeline how all these beta-lactamases evolved. So if someone who is speaking about, okay, my patient is growing classical or so-called broad spectrum beta-lactamases, which means you can't use any sort of penicillins and first and second generation of cephalosporins. Penicillins maybe it's uridopenicillins, carboxypenicillin, or maybe like aminopenicillins also. You can't use any penicillins and first and second generation cephalosporin. Suppose if someone is speaking, so my patient is having an ESBL. So what exactly it means? So above antibiotics along with third generation cephalosporins and along with monobactam, that is aztreonam, is not going to work for your ESBLs. By definition, if you use BL-BLI combination, okay, piperacillin tazobactam, ceftriaxone sulbactam, ceftazidime tazobactam. So by definition, these BL-BLI combination should work against the ESBL, but that is not the scenario at the bedside. Okay, I'll tell you why it is not so. So then something called like Oxa and AMC, I told above all the antibiotics, along with they are not like sensitive to cefamycin group of antibiotics like cefmendol, cefotetan, cefpirom and all those things. Again, last we came across that is metallo-beta-lactamases, IMP, VIM and NDM. So they are resistant to all these along with the carbapenems also. Then we left only with polymyxin group of antibiotics. So what are the other mechanisms other than these destructive enzymes? Okay, I showed there is something called outer membrane, so which is having a porine channels. Okay, whenever there is a mutation, these porins are meant for the entry of the nutrition and all the stuffs for the bacteria. Even antibiotics also are going to enter through these porine channels. Whenever there is a mutation, these porine channels are going to not allow the antibiotic inside the cell, bacterial cell. So other thing is there are lots of mutations, okay, OPRD, OMPC, so lots of research is happening to target these kind of mutations. Okay, there is something called mutation prevention concentration. Now lots of studies are going around how we can tackle this mutation which lead to resistance. There is something called efflux pumps. Okay, most common efflux pumps in Pseudomonas aeruginosa is MEX-AP, OPRM. So even though antibiotic entered into the bacterial cell, it's going to efflux out through this mutation which causes efflux pump activation. Again, what is the option? I told if your lab is giving the organism is ESBL. Okay, so its option only is with the carbapenems. Okay, you can't use any BL-BLI combination. If at all, if they given an MIC which is less than 1.5 or maybe less than 2, then only you are able to use the BL-BLI combination. So take home message, if someone asked in your exam what is the option for ESBL, carbapenems. Okay, so there is a high failure rate